Good morning, good afternoon, everyone. On behalf of PACT, we are pleased to welcome to this webinar named Telling the USAID-Zambia Community HIV Prevention Project Story, otherwise known as Z-CHPP, a story of collaborating, learning, and adapting. Between 2015 and 2022, PACT, with support from its partners, USAID, implemented the Z-CHPP program in Zambia. It has been an incredibly successful community-based HIV program that reached almost 2 million at-risk girls, women, boys, and men. A key component of the program included DREAMS, which has, as many of you know, is one of PEPFAR's flagship initiatives. Today, we are pleased to share with you the lessons and best practices from implementing this project. My name is Mariana Balampama, Deputy Regional Director, Africa at PACT, speaking from Dar es Salaam, Tanzania, and I'll be serving as your moderator today. We have an exciting agenda where we'll hear from key stakeholders, particularly the government of the Republic of Zambia, USAID, and PACT. We'll notably hear from community workers, as well as one young woman who participated and benefited from the DREAMS program. We will hear insights of the project's collaboration in delivering services and key innovations and best practices. Finally, we'll hear about the vision of what lies in future for DREAMS programming in Zambia. Wow, we already have over 100 participants here today, and I welcome you all. Please introduce yourselves in the chat box so that we know where you're tuning in from. Type in your name, title, organization, and country. Throughout the webinar, please feel free to interact in the chat box with our speakers. Just type your comments and I'll be addressing them as we go along. Please also indicate to whom your comment is addressed to. I would like also to let you know that this webinar is recorded and we'll make it available afterwards. Without further ado, I'm honored to introduce to you Caroline Anstey, PACT CEO and President, to kick us off with opening remarks. Welcome, Caroline.
Thank you, Mariana. Having some challenges with the technology there. Good morning, good afternoon, good evening. My name's Caroline Anstey. I'm the President and CEO of PACT. It's an absolute pleasure and an honor to welcome you all to this closeout webinar for the Zambia Community HIV Prevention Project that you're going to hear referred to throughout the morning as Z-CHPP. This is a program that all of us, I think, on this call and many people beyond are incredibly proud of, and that we feel has very important lessons on the importance of evidence, data collection, real on-the-ground community leadership, lessons that we can all learn and benefit from. Implementing this project would, of course, not have been possible without the generosity of the American people through USAID and PEPFAR. Our sincere thanks also go to the government of Zambia, who are going to be represented here today for their very dynamic coordination role. I'd also like to thank the local and international organizations that have been our partners on this project. And of course, above all, the communities, the girls, the volunteers, the parents, who made this project such a success, and without whom this project wouldn't have been possible. And I need to enter a personal note here. In May, Mariana Thomas, who you'll hear from later, our country director, and I traveled to Kasanda Dreams Center in Central Province. It was an incredibly moving experience to hear from the Dreams girls, from their communities, from the community workers. But more than moving, which it certainly was, it was really inspirational, exciting. it opened up so many avenues of potential for all of us to take forward. And it's really sealed in my memory going forward. Today, as Mariana said, we celebrate the impact of Z-CHPP and the data-driven, evidence-based approach that is so much at the heart of PAC's work and so many of you on this call. As Mariana said, Z-CHPP reached 1.9 million people with all sorts of interventions. Let me just read you some of the numbers. 1.9 people from priority populations completed a standardized HIV prevention intervention. Nearly 765,000 girls graduated from the Safe Spaces program, leading to increased condom use and greater awareness of HIV status, critical elements leading to reduced HIV incidents in that very Safe Spaces program, which has been so applauded. The Z-CHPP project also served nearly 525 individuals with PEPFAR OVC programs and distributed more than 61,000 HIV self-test kits during its 7-year run. You will hear more about this, and I think you will hear also the stories, the evidence, the data, the results behind the numbers. The numbers are impressive, but what really matters is how this project has taken hold and how it's been scaled up, and how we hope to scale up those approaches further as we and our partners will go forward. And of course, it's central to the work of USAID and PEPFAR. So with that, Mariana, I'm going to hand back to you and look forward to listening. I think it's going to be a great event.
Thank you so much, Caroline. And now I'm honored to welcome Arlene Feary, Senior HIV Prevention Advisor from the Health Office at USAID Zambia, who also served as Z-CHPP's AOR. Welcome, Arlene.
Thank you, Mariana. I hope you can hear me.
Yes.
Okay, thank you. Good afternoon, everyone. So all protocols observed. I can see Dr. Osborne from NAC and our Minister of Health colleagues. I apologize, I'm not sure who's on the line. Okay, I can see Mr. Makupe and everyone, PACT leadership, everyone who's on this call. Thank you very much for joining the celebration of this amazing project. My internet is a little bit unstable, so I'll switch off my video. I just switched it on so that people could see me, so I'll switch it off just to save bandwidth. Thank you. Yeah, so for me, this is a bittersweet moment because on one hand, I am happy to celebrate the success of the Z-CHPP project. And on the other hand, I'm sad that this project that, I have known for the past 7 years, that I have been so closely involved with, is, coming to an end. So yeah, you can understand my happiness and sadness at the same time. But please, let me just start by thanking all the partners and stakeholders who played a part in ensuring that this project was successful. The Ministry of Health for providing the framework that opened the doors for the DREAMS initiative to operate in the various districts. The Ministry of Education for ensuring that the young women could complete their education either by coming back to school after having dropped out, or just staying in school if they were at in danger of dropping out due to not having the resources to stay on. So we thank the government of Zambia through these two ministries. We thank the multiple technical education, vocational and entrepreneurship training centers that provided economic strengthening skills to the adolescent girls and young women, to the communities and parents of these young people whose support made it possible for this project to succeed, and to the Z-CHPP team led by PACT for their strong championship of critical results over 7 years. It was an amazing team, and I will definitely miss the team, so hats off to the PACT team that you had on the ground in Lusaka, but also the team that supported them, from HQ. They really did a good job of ensuring that this project delivered on what it was set up to do, and that is, reaching the different priority populations, especially our adolescent girls and young women. So thank you to these groups. Just to mention that USAID Z-CHPP implemented the first flagship DREAMS program in Zambia. I remember the project had just been awarded when OGAC announced the DREAMS program. We spent endless hours of meetings, trying to think, how is it going to look? How are we going to do this? And, because of the resilience and the interest in really making sure that this was going to succeed, with Z-CHPP, USAID, Ministry of Health, we managed to design the DREAMS program, which has been replicated by the follow-on projects, as well as our colleagues on the CDC side. So thank you for that. This is a unique program, which strengthens HIV prevention skills throughout a young girl's life. It's a catalytic program which protects the young populations, and the project was able to provide needed medical services and to prevent the spread of infection, but they also developed beneficiaries into productive, responsible adults who also became peer advocates against risk behaviors. The program, as we probably all know, offers financial literacy training, savings groups formations, entrepreneurship, business startup support, and other skills that help a young girl or a young woman to be able to manage the different vulnerabilities that eventually lead to HIV infection. It's a documented point that adolescent girls and young women who are not in school are more at risk of acquiring HIV. And through this program, more than 66,000 vulnerable girls were provided with educational support to stay in or go back to school. We also heard from the earlier speaker that Z-CHPP provided quality prevention services to almost 2 million priority populations and nearly 276,000 with HIV testing and linking them to care, whether prevention or ART. And they provided more than 118,000 young women with family planning services that helped these young women avoid early or unwanted pregnancies. And more than 730 adolescent girls and young women were referred for gender-based violence services. These are just some of the results that this project scored. in this session today, we're going to hear more about what the project was able to do. But all these results have changed the lives of the communities and individuals they served. And as USAID, we are proud to be associated with the successes of this project. Thank you again to PACT, Ministry of Health, and all the stakeholders that helped this project to succeed. I thank you.
Thank you so much, Arlene, for those powerful and kind words. Now I'm pleased to welcome Dr. Connie Osborne, Director General of the National AIDS Council of Zambia. Welcome, Dr. Osborne, for your brief remarks.
Thank you very much. Mr. Alex Makupe, representing the guest of honor, Professor Lakson Kasonka, the Permanent Secretary of the Ministry of Health, senior government officials, the PACT team, both at headquarters, regional and national levels, the USAID Zambia Mission Director, project key implementing partners. Let me say all protocols observed. Good afternoon. Zambia, with 1.3 million people living with HIV, remains one of the countries that have been hard hit by the HIV epidemic. Despite the significant progress that we have made in saving people's lives and attempting to control the epidemic, we are not out of the woods yet. Last year alone, we had about 38,000 new infections, up to 40%, actually approximately 40% were in adolescent and young people, with 7 out of every 10 infections in these adolescents and young people being in adolescent girls and young women. And that is why the DREAMS project is very, very important in Zambia. We are also used to calling it DREAMS, but I understand it stands for determined, resilient, empowered, AIDS-free, mentored, and safe. After 7 years of implementing the USAID Z-CHPP project, also known as Zambia Community Health Prevention Project, the National AIDS Council takes pride in having been a key supporter of the project. Indeed, it is a bittersweet moment, but we believe that the closeout is not really the end of the DREAMS project. If anything, it is going to be succeeded through the USAID control of HIV epidemic for key and underserved populations under 2 projects, which will be known as Checkup 1 and Checkup 2. PACT, of course, is going to be part of those 2 projects, providing technical support. So after the successful physical celebration that we had about 2 days ago, we actually had another closeout session 2 days ago. Today, we are now celebrating it virtually. And I acknowledge the presence of all the beneficiaries on this project. We are reliably informed that the project was able to make a difference in the lives of over 2 million Zambians, including 850,000 adolescent girls and young women. One of the success factors, in addition to the fact that it had and still has tremendous community support. I think the communities are at the center of this project. This project was able to engage government at all levels throughout its planning, its implementation, and transitioning of activities. As the National AIDS Council, we truly enjoyed the partnership and collaboration with PACT on the project, through our Adolescent Girls and Young Women National Coordinator, and at the sub-national level through our provincial AIDS coordinating advisors and the district AIDS coordinating advisors. So, as a country, we continue now more than ever, seeing as we have just a little over 7 years left, we are very committed to ending AIDS as a public health threat by 2030. So we have 7 years to double our efforts and to give it all our whatever ammunition that we have, with a particular emphasis, we think, on prevention and maintaining, of course, people on treatment. I'm saying prevention because for every new infection that we do not prevent, that's one more person that needs treatment for life. Would like to thank, or rather to join the rest of the country and all the HIV key stakeholders in thanking the US government and its people for its continued support and funding towards HIV prevention, treatment, and care activities in Zambia. With your continued support, Zambia's plan to reach epidemic control and end AIDS as a public health threat is definitely forthcoming. We look forward to our continued collaboration and partnership with PACT and also with the new, with Checkup One partners, I think it's CIDES, and also Checkup Two with JSH in implementing these dreams and community HIV prevention intervention for the Zambian people. Thank you very much.
Thank you so much, Dr. Osborne, for those enlightening remarks, and thanks for your collaboration. And now I have the singular honor to welcome Dr. Alex Makupe, Director of Clinical Services at the Ministry of Health Zambia, who is today representing the Permanent Secretary of the Ministry of Health. Welcome, Dr. Makupe.
Thank you very much. Thank you. And let me go on to recognize the presence of Director General Dr. Osborne Kony, the National AIDS Council of Zambia, the USAID Zambia Mission Director, Mr. Peter Webler, PACT Zambia Board Chairperson, Mr. Jumbe Ngoma, senior officials from the government of the Republic of Zambia, UNAIDS country representatives, distinguished delegates, ladies and gentlemen, a good afternoon. I bring greetings from the Permanent Secretary, Technical Services, Professor Lacson Kasonka. He could have loved to be here, but he finds himself in two equally important activities. So he asked me to come in and sit in for him. I'm equally happy that I can be part and parcel of this activity. It is with great honor that I'm here today to witness the close out of a momentous project. You may wish to know that HIV/AIDS remains a challenging issue globally, but more so in Zambia. The HIV prevalence remains very high at 11.3%. We therefore have a big course before us to institute HIV preventive measures across the frontiers of this country. I am greatly delighted that we have solutions and best practices to ride on for our journey to ending HIV and AIDS as a public health concern, such as the USAID supported Zambia Community HIV Prevention Project. Ladies and gentlemen, the government of the Republic of Zambia takes pride in the successful implementation and performance of the USAID Zambia Community HIV Prevention Project, USAID Z-CHPP, which mitigated the vulnerability of 1,933,895 at-risk girls, women, boys, and men via biomedical, educational, and economic strengthening interventions. Ladies and gentlemen, Z-CHPP included PEPFAS determined, resilient, empowered, AIDS-free, mentored, and Safe Girls Mentorship, in short, DREAMS programming, and the project successfully reached over 825,000 vulnerable adolescent girls and young women. Z-CHPP also engaged the government at all levels throughout the implementation and transition of its activities. Most importantly, this project came to support JRZ efforts to combat HIV/AIDS epidemic in Zambia. Interventions were also aligned with the Zambia consolidated guidelines for treatment and prevention of HIV infection. This government will fight the big battles, public health concern, HIV, TB, through stronger partnerships. And His Excellency, the President, always talks about this. Ladies and gentlemen, the United States government has been our all-weather partner in supporting and funding HIV prevention, treatment, and care activities for Zambians. We say thank you for the support for supporting our government and assisting us in strengthening the HIV service delivery systems, including the continued support in HIV prevention programming to attain the epidemic control by 2030. Ladies and gentlemen, we look forward to carrying on the legacy of USAID Zambia Community HIV Prevention Project. As a government, our role is to coordinate, facilitate, and provide policy guidance in implementing these interventions. Above all, create an enabling environment for all partners to contribute to the fight against HIV and AIDS. We will pave the way to other interventions and ask PACT and partners to share their expertise. We promise to do our best and do so much more for our people. Thank you very much, and may the partnership between the United States of America and the government of the Republic of Zambia flourish for many, many years to come. May God bless Zambia. Thank you.
Amen. Thank you so much, Dr. Makupe, and please pass our regards and gratitude to the Permanent Secretary. And thank you again to all our esteemed panelists. To anyone who is just joining, a warm welcome. Please introduce yourself in the chat. And now we are going to hear the story of Z-CHPP. To start us off, we'll hear from Thomas Kipingili, the Chief of Party of USAID Z-CHPP project, who will talk about the key approaches that the project utilized in achieving its impressive results. Welcome, Thomas.
Thanks, Mariana. Dr. Alex Makupe, Director Clinical Care Services, representing the Permanent Secretary, Professor Lakson Kasonka, Dr. Connie Osborne, Director General of National AIDS Council, Aline Piri, Senior HIV Prevention Advisor and AOR for Z-CHPP, and PACT leadership, Caroline Anstel, the PACT CEO and the President, distinguished delegates, ladies and gentlemen, protocol observed. Good morning, good afternoon. My name is Thomas Kipingili. I'm the Chief of Party for USAID Zambia Community HIV Prevention Project in Zambia. And I'm thrilled to take you through this brief presentation. And yeah, next slide, please. Yeah, the USAID Zambia Community HIV Prevention Project was designed to accelerate progress towards Zambia's goal of reducing new HIV infection by increasing adoption of high-impact HIV prevention services and protective behavior, which are key focus for priority populations, comprising of adolescent girls and young women, people living with HIV, mobile population, and discordant couples, and non-injecting drug users. A 7 years, 79 million USAID project was being implemented by PACT with 3 implementing partners and 6 sub-partners, and it was implemented in 14 districts in 7 provinces in Zambia. The USAID Z-CHPP support the government of the Republic of Zambia efforts towards reaching the UNAIDS 95 targets. The project started as a community HIV prevention, and then DREAM came on board, and the project evolved over time, and therefore there has been a lot of reflection, learning, and adaptation to ensure the project achieved its intended results. Next slide, please. Yeah, this theory of change states if community systems are strengthened and better coordinated, then there will be more effective, support-tailored, local, evidence-based behavioral change and the high impact services to address the key drivers of HIV transmission, and ultimately that will lead to reduction of new HIV infection. Next slide, please. Yeah, this slide provides a snapshot of the key project approaches and the interventions for both the DREAMs as well as the community HIV prevention components of the project. And as you can see, and next, yes, and as you can see, under the DREAMs, the project used different approaches to identify and recruit the adolescent girls and young women into the program. And these include hotspot mapping, use of trained mentors and connectors, engaging the local government authorities, parents, guardians, as well as sexual partners of adolescent girls and young women in the recruitment of the adolescent girls. And under the school-based HIV prevention intervention, the project provided scholastic material, bursary support, as well as referral for high-impact HIV prevention services. And for the older adolescent girls and young women, the project provided combination prevention intervention. And these include behavioral, biomedical, as well as structural. In addition, the project provided parenting education, digital literacy, and the mental health, which were also key components of the DREAMs component project. And on the community HIV prevention piece, the peer educators and the lay counselors identified and recruited service users and through hotspot mapping, and provided them with HIV prevention education, testing, and referral as needed. A scattered referral was one of the critical components of the project. Next slide, please. Yes, after highlighting our service menu or technical approaches and the interventions, I will now highlight some of the key results that the project has achieved during the life of the project. On the community HIV prevention piece, we have reached over 1.9 million individuals, priority population, with the standardized HIV prevention messages. We tested over 275,000 people, and also we linked to care over 29,000 people who are found positive. And also we distributed HIV self-test to kids to priority population to amount of 62,000. We distributed condom, male as well as female, and we distributed over 18 million male condoms to priority population, as well as over 500,000 female condoms. Next slide, please. And on the DREAMs piece, we enrolled over 800,000 age-wise into the DREAM program, and these also received high-impact HIV services. And we established 53 DREAMs centers and recruited and trained over 700 mentors into the program. On HIV testing, we reached, under the DREAM program, we reached over 96,000 AGY, and also over 93,000 AGY access to modern family planning services. Next slide, please. Yeah, capacity development support to our partners was also one of the key project interventions. And during the life the life of the project, we managed to provide capacity development to our 6 local partners who were part of the consortium. And their organization as well as technical capacity were actually strengthened. And we're proud to say 2 of our local partners are currently priming USAID awards. And these are the Zambia Center for Communication Program and as well as the Catholic Medical Mission Board of Zambia. As part of strengthening community structure, district and community structures as well, we also strengthened the capacity of 14 districts, HIV and AIDS committees. And these were actually in the district that were implementing the project. Next slide, please. Yeah, after 7 years of implementation, we have learned a lot, and we have a few reflections that we want to share with delegates around in this webinar. Our partnership, we cannot say enough about the partnership that we had, the great partnership that we had with the great partnership that we had with the Ministry of Health, Ministry of General Education at all levels, which contributed to improve availability of and the quality of HIV prevention services. The community leader engagement was also very key. This also provided an opportunity for them to influence community perception as well as increase its service uptake of HIV prevention services. We were very strategic in our recruitment, and we did recruit project volunteers from the same communities where they were coming from. And that's also helped the communities to gain trust as well as build rapport with the people that we served. Adaptive management was also one of the key lessons during particularly during COVID, which enabled us to stay focused, but also being able to manage to reach the project intended results. Next slide, please. Yeah, I would like to sincerely thank the US government through USAID for support, as well as the government of the Republic of Zambia for the support that rendered to the project throughout the implementation. I also like to thank NAC, the National AIDS Council, for partnership and collaboration during the implementation of this project. But also I would like to thank our implementing partners and the subs who made the implementation of this project also positive. Thank you very much. Next slide, please. Yeah, over to you, Mariana. Thank you very much for listening.
Thank you so much, Thomas. And a reminder to our participants, please share your comments, reactions, and questions in the chat box. Up next, we'll see a video that will tell a story of a community-based component of Z-CHPP that reached priority populations across Zambia.
This one takes the side, the other one takes the north, the other one takes the south. And as we're going, we'll be going stand by stand. So when you come here, you can spend about 5 to 6 hours just giving information on HIV and AIDS. These are called seasonal farmers. So these guys, they bring charcoal from far away, from Kasama, Kapili. Most of them, they are women. They've left their husbands there. And then when they come here, they mingle with the male from Mandevu. This couple, as we were passing by, they called us. They wanted to know information. They're a dishonored couple. One is positive, one is HIV negative. So they wanted to know more on how they can live their life together. As this is explaining, he's also talking about the importance of disclosure to your family, because family support is also important. Since I'm from Mandevu, so they know me. So it's very easy for me to talk to them. One decided to go to the clinic and have an HIV test. The other one decided to go and do STI screening. What we're looking for is for us to control the HIV virus. The virus was already there. There's nothing we can do. What we have to do is just to control it. So what I'm hoping is for me to see a Mandevu which has got no new HIV infections. That's what I'm praying for, that's what I've been working for, to see a Mandevu with no new HIV infections. And also to have people with HIV living a healthy, positive life.
There was a time really when I resisted to be tested. In the first place, I didn't believe that I had HIV. But when finally I succumbed to tuberculosis, I tested for HIV, and I was found to be positive. Then I just lost my wife, my first wife. My first wife died to HIV. I hated myself. The closest I could think of was committing suicide. But then because I had 2 little children, I had to rethink my position. If I take poison or if I don't do anything about my status, what would be the way forward for my children? And I've been living on ART ever since. It's at a time when people were saying this is a curse from God, this is a punishment from God. So then I said, if this is from God, I'll go back to God. So I was under divine instruction. Go speak about this. Yes, stigma is there, discrimination is there. It's not easy. Sometimes you hear people speaking these things behind your back. But then you decide, for the wellness of community, let's speak about it nonetheless by restoring my health. So then this, I shouldn't keep it to myself. I should then take it out there so that I can be a comfort to those that need to be comforted. Let as many people as possible come on board, especially my fellow pastors. There are traditional norms and practices in our land which are perpetuating the spread of HIV. You see, there is hope because now they are being tackled at micro level, at family level, and people are slowly awakening. So there is hope. It's possible we can make it HIV-free Zambia.
Wow, wasn't that inspirational? Thank you for all the love. And up next, we'll hear insights on advancing community-based HIV prevention strategies in the Zambian context. And for this, I welcome Charity Siame, Deputy Chief of Party of the Z-CHPP program. Welcome, Charity. Charity, you have to unmute yourself.
Thank you, Mariana. Good morning, good afternoon, and good evening, everyone. My name is Charity Siame, the Deputy Chief of Party for the USAID-funded project. And I will take you through the next few slides where we're looking at lessons learned in working together to achieve epidemic control among priority populations in Zambia. Next slide, please. Okay, so I must mention from the onset, one of the very first things we did when we were awarded this project was to go on the ground, conduct a formative study to understand some of the key barriers to HIV prevention behaviors and service uptake. What did we find on the ground? So we found out mobility of some of the populations was still a barrier to HIV prevention. We saw in the other video where there was talk about some of the mobile populations that we have, and these are the seasonal farming communities, for example. We have the truck drivers, the traders, and the miners in most of the catchment areas that we worked in. We also found that there was still fear of stigma and discrimination among populations, the fear of what will or how will my community accept me when they do discover that I am HIV positive. We also found that there was a lot of misconception about HIV among the communities that we were going to serve. The issue of gender inequity and violence is something also that was very predominant, and mostly because of some of the cultural barriers and factors that still exist within the communities. Last, we also found one of the barriers was that of limited service at health facilities. And in this, I must explain that when we talked to the people on the ground during the formative research, one of the biggest concerns, especially from the men, was that they felt they didn't have men-friendly corners within the health facilities where they could go and access a health service and feel as if they were in a safe space. Next slide, please. Thank you. So another barrier that we found, and this one was around HIV testing behaviors. And for this one, we found quite a lot of feedback from here. One of the findings for this was that men within the communities had poor testing or health-seeking behaviors than women. We also found that men could only test when forced to accompany their spouses for testing, and were more willing to access HIV testing services through mobile services as compared to going to the health facility itself. We also found that men were more willing to be tested if it was found that the spouse was HIV negative. So that right up in the box there is just feedback from one of the female counselors in the facilities who said that men do test when the counselors follow them to where they are. So this speaks to the point of them not wanting to test within the facility, but going to access their testing services through mobile services. Next slide, please. So what did we do? So as a project, we used a three-phase approach in our interventions. And the three phases that we used in carrying out our activities, they were divided into three, which is biomedical, behavioral, and structural. So under biomedical, this is where we have the HIV testing cascade. And there we had the mobile testing, the index testing, the VCT, which happened predominantly in the dream centers. So we called this a community VCT. Later on, towards the end of the project, we also introduced a social networking strategy, and data from that also shows that we did actually get quite a high number of high positivity from the social networking strategy as well. So we also had HIV self-test, which was implemented as well. And then the others include family planning, condom promotion, as well as PrEP referrals, which we did in collaboration with other partners that we worked with during our implementation period. Under behavioral, this is where the bulk of our SDCC interventions fell. And here we had the cultural communication activities that we did through the religious and community leaders within the communities. We also used fully utilized media platforms, different media platforms, radio especially, and for the DREAMS interventions at some point, social media was very popular among the adolescent girls and young women as a tool for dissemination some of the information. We also utilized gender transformation champions. We utilized the coaching boys to men intervention, which my colleague will talk about later on in the presentation. Under structural intervention, this is where the bulk of our economic strengthening activities fell. So here we had the savings and lending groups that were put in place. We also had the girls in the dream centers being coached and having employability skills and different life skills just for them to have a head-on start in their different life aspects. Gender mainstreaming was something that was very important to us. So we ensured that in all the activities that we implemented, there was a component of gender actually embedded in the interventions. Of course, the issue of stigma and discrimination is something that we worked around using our various SBCC platforms. Other direct services that I will quickly make mention to are the vocational training, apprenticeship, and internships that opportunities that we give to adolescent girls and young women, which my colleague again will talk about in the next presentation. Next slide, please. Okay, so apart from the three-phase approach that we use, as a project, we work at strengthening community systems for HIV prevention. How did we do that? As a project, we had a structure that was very much district level oriented. We had staff in the national level, but we also ensured that at district level, we had staff ensuring that they were grounded and they followed up with the different beneficiaries on the ground that we had. So at the district level, for example, would have an a technical HIV expert, would have an economic strengthening officer, would have an M&E officer as well, just to make sure that they were working hand in hand with the lay counselors, the peer educators that we had on the ground. And then lastly, we also had a very robust data monitoring system, which we're very proud of as a project. And for us, this ensured that we're on track, and all the time we were tracking our indicators, we're reviewing our data, cleaning up our data, and reporting accurate data to the donor at the required periods. Next slide, please. Okay, so I'll talk about some of the initiatives for success as a project. So as a project, really, we worked under guidance from global best practices. For example, all our HTS strategies were an adoption of the global test practices, the WHO strategies that were in place. So whether it was HTS, whether it was self-test, whether it was index testing, we adhered to the actual policies and guidelines with regards to this. We also had a very strong community engagement approach. In the video, we saw the gentleman in the video speaking to how it was easier for him to reach out to clients because he was from within that community where he was actually working in. So we worked very closely with the people on the ground. All our peer educators, all our mentors, all our lay counselors were actually from within the communities that they were working in. Information dissemination is something that I spoke to under the SBCC strategy. So we had a very strong information dissemination strategy in place. We did not work in a silo. We worked in collaboration with different partners. I mentioned in an earlier slide that we work with partners such as JSI for our PrEP provision. We provided it as a referral service. So the only way we could succeed was to work in close collaboration with partners that were actually stronger in providing such services on the ground. Lastly, we offered differentiated service delivery. Our approach was client-centered, and as much as this was client-centered, we ensured that integration was happening at all aspects of our program. So these are some of the initiatives for success that we use as a project during our 7-year implementation. Next slide, please. So who did we reach? I know the previous speaker did allude to some of the people that we actually did reach out during our implementation period. So this is just to show a further breakdown. Our greatest reach was towards the adolescent girls and young women. And among those, obviously, we did not leave out the sexual partners to these adolescent girls and young women. We had quite a number of despondent couples as well in our program implementation. We had the mobile populations as well, which I spoke to in the earlier slide. We also had non-injecting drug users, and lastly, people living with HIV/AIDS. So this number represents the 1.9 reach that we had over the 7-year implementation of our project. Next slide, please. Okay, so lessons learned. One of the biggest lessons we learned during implementation was that of the importance of having a risk assessment tool. You'll notice if you look at the graph in front of you, when we started out as a project, we had a very, very low positivity. And this is because at that point, we're doing mass testing. We're not screening the people that were coming forward for HIV testing. But we introduced the risk assessment tool, which is our FY19. And at that point, you can see an increment from 1.65% the previous year to 9% and eventually 25%. So this is all attributed to the provision and use of the risk assessment tool in the sites where we implemented our project in. Next slide, please. Okay. Another lesson learned was that around index testing. So as a project, index testing was only introduced in the third year, again, of our project. This is FY19. So again, just quickly, if you look at the graph in front of you, you'll be able to see the bar that's in orange. That's actually representing our index testing modality reach. So from the time we introduced the index testing modality, we reached out to, we actually found more positives on the ground, and this really was a plus on our end. The bar in orange is the VCT, and this one represents the testing, the positivity among the girls in the DREAM centers. And then the bar in blue, those are the mobile testing numbers. So generally, all in all, we had a higher positivity under the index testing modality. Next slide, please. Okay, so just quickly, some of the key reflections in reaching our 1.9 million at-risk girls, women, boys, and men. So I did allude to the fact that the risk assessment tool was something big for us. It's something that worked for us. And the data looking at the positivity in the use of the risk assessment, because of the system that we had, we could actually break this national level. So this is something that really worked well for us. I did also talk about the index testing modality. I won't focus much on it. I think I explained that in the previous slide. And then the third bullet, obviously, just to say, success of HIV case finding varies depending on HIV testing modality. With index testing consistently resulting in higher yield. I think I did allude to that as well. And also, I did mention that we started SNS towards the end of the project, that even from the data that we have, we could tell that we did, the positivity for SNS was also quite high when you use this approach. And then lastly, just to mention that it's important to select an optimal blend of targeted HIV testing strategies. For us, it's not a question of one cup fits all. I think we learned during our implementation that you needed to be innovative, you needed to be creative, and you needed to be up to speed with some of the global trends around HIV testing, around programming. So this is something that really worked for us as a team. Next slide, please. Okay, so lastly, I'll speak towards the data for decision making and adaptive programming. I did mention earlier that we had a very robust data management system. We use the DHIS2 data management system for managing our data. This is something that we're proud to speak of, and we have actually handed over the DREAMS database right now to the partners that are following on to Z-CHPP, and these are the Checkup One project. So I mentioned that site level data review meetings were held, and this is something that really, really helped because we had a targeted approach. When site X was trailing behind with regards to data management, we could pull out the data, develop strategies, and help them build whatever challenges that they had in terms of data management. I did mention that we had teams on the ground working around the M&E the M&E team. So obviously this really helped us to ensure that we're up to speed. Should there be any gaps, we could easily identify them. For example, the issue of low positivity, we could identify low positivity in site X, for example, because of the periodic review of our data. And this is something that really, really helped us as a project. And then lastly, the hotspot mapping, which my colleague spoke about earlier, is something that worked. We had to do this periodically. Obviously, sometimes you get to a level where you reach saturation, but we needed to re-strategize. We still needed our numbers. So hotspot mapping is something that really, really worked for us as a project. Next slide, please. Thank you. That was my last slide. Thank you for listening.
Thank you so much, Charity. And up next, we'll hear about Z-CHPP's innovative and acclaimed DREAMS program, specifically around innovations that emanated during the implementation of the program. And I welcome Lisa Chileshe, who was the project's Dreams Manager, to present the innovations to us. Welcome, Lisa.
Thank you so much, Mariana. Good morning and good afternoon, everyone. As Mariana mentioned, my name is Z-CHPP, the Senior Program Manager for Dreams in Zambia. And I'll be taking you through a brief presentation just to highlight some of the key innovations that we enjoyed implementing on the Dreams project. So we can get right into it. Next slide, please. So just to kick us off, I have a slide on the screen now, which shows you a comprehensive package of the Dream services that were provided to the girls. We had dissected these into primary and secondary services, depending on at which point the girls were actually accessing these services throughout their Dreams journey. And it was quite an extensive package. And we really did our best to enrich the story of the access to these services, because these were layered on one after the other. And obviously, the more you access, the more we build that resilience in the girls. So this is just a list of services we provided. Next slide, please. So the snapshot I have on the screen here is just to give you a bit of a context when it comes to where exactly these services were provided. And the two key spaces that you can picture are the Dream Center and Safe Spaces. So the Dream Center you can picture as a service provision hub that was open 7 days a week, where all of these services I just showed you in the previous slide were accessed. While Safe Spaces were now the independent small meeting spaces that took place at different locations within the community. And really this was decided on as the girls would agree with their mentor, who was their facilitator, as to where they were more comfortable meeting to learn about these different pieces of information about how to prevent HIV and where exactly to access these services. Next slide, please. And as for the structure of Dreams, so we had the USAID Z-CHPP project providing overall technical guidance at the top. And then directly beneath that, we had our different implementing partners that Thomas alluded to in the beginning at during his presentation. So immediately beneath the implementing partner, that's when you found the Dream Center managers, who were the overall authority that were responsible for managing all operations at the Dream Center. And directly beneath that, we then had what we used to call a Dreams Connector, who was really doing that, connecting the Dreams girls to this project. And they would go into the community and do the hands-on identification of who was eligible to actually join the program. And this was done through a robust screening process. There was a tool that was designed to do this. And this is where we got to gauge what the levels of vulnerability to contracting HIV were. So this was done through connectors who were then supervising the mentors who would take the girls through safe spaces. And interesting enough, in those safe spaces, the smaller groups that I was talking about, we actually ended up identifying who we refer to as Dreams ambassadors. And they ended up being sort of like pioneers for the work that we were driving, because they had that extra drive to really support on the next level what the project was actually here to achieve. Next slide, please. And so just lightly highlighting what the Dreams journey looked like, we started on the far left with your active screening and orientation into the program, which was done by a connector, like I mentioned. And then the connector would then refer you to a mentor who will place you into a safe space. And while you are attaining that safe space, you are really going to attain it based on your geographical location. You get to choose, I'm from this community and this is a safe space location that's closest to my house. And then you get placed in there. And while you're going through this 13-week Dreams journey, under the guidance of your mentor, along with 25 other peers, you will then learn so much information about financial literacy, how to prevent HIV, as well as accessing these high impact services that I highlighted in the beginning. And then as we did our reporting, we would then classify at which level did you access these services? Did you access the primary package or the secondary? And along that as well, there was a lot of information about economic strengthening that the girls would get to learn as well. Next slide, please. So just to quickly highlight some of our key innovations, I would love to start with the COSO Girls, which was an enterprise that was started right here in Dreams Zambia. And before I go any further, I would like to just emphasize that the word COSO is not an acronym, but it's actually a word that means peace. It's in one of our local languages here in Zambia called Lozi. And I'll explain just now why exactly that word was chosen by the girls to name this initiative. But really the causal enterprise came about as a sort of like a skills empowerment program where the girls were learning the skill of sewing, and specifically sewing reusable sanitary towels to make products that were finished products they could distribute amongst themselves. This was really meant to address the issue of menstrual hygiene poverty that the girls were experiencing, because some of them would skip school simply because they were on their period, and that made them very uncomfortable. They didn't even have access to sanitary towels. So tailoring supervisors were engaged to equip the girls with this skill, and then the girls later cascaded this to fellow AGYW. And using this model, we ended up empowering hundreds and hundreds of girls who learned the skill. We provided these sewing machines and startup materials that they needed. And from there, the innovation took off, and they made and supplied so many reusable sanitary towels amongst themselves and also to institutions that actually needed this. And then the impact, really, we're talking about these very impressive numbers in revenue that I have up on the screen. We had so much money that was generated just through the production of innovative products like face masks, because this is something that we did to respond to COVID using the causal enterprise. And there's more there. So next innovation for me, please. And then here I just have a quick gallery that I wanted to flash of what our economic strengthening activity looked like in pictures. We have well-established income generating activities. We have young women there sharing out their money during share out after participating in savings practices as learned from the project. Next slide, please. And then for innovation number 2, I thought it would be good to highlight mental health as well, and the support that we provided to our girls using this. This really came about as a key innovation because we needed to do something extra to support the girls and their mental state throughout their life in dreams as well as afterwards. And this was done through mental health specialists who were engaged to train a total of 131 mentors who were administering a patient health questionnaire that was determining the level of emotional stress they were facing. After this screening was done, they were then allocated to the appropriate group or individual psychotherapy, where they were then impacted and they received this psychotherapy that was appropriate for what they were facing. We ended up reaching over 9,000 adolescent girls and young women that benefited from this. And we're also proud to highlight that 94% of them really reported that reduction in stress levels as compared to pre-intervention. Next slide, please. And for digital literacy, this was also one of our key interventions that was really, really robust and praised amongst the girls. Here, we were teaching the girls basic computer skills. And really why this was important is because it equipped the girls to actually participate in the corporate world. We live in a digital era, and this is something that's undeniable. This is something that's not going away anytime soon. And learning to use a computer, learning to identify the software and hardware parts of the computer really do place you in that position where you can actively participate in the economic activities that are going on around. And after we empowered these girls with so much economic strengthening skills, we needed them to even learn how to promote some of these small businesses that were running on these platforms. So this intervention came in very key. And we provided this in form of a 5 to 10 day program that was delivered by trained facilitators. And they were covering skills, they were covering topics like learning computer soft and hardware, understanding how Microsoft Office works, understanding how to craft a CV, as well as how to use social media to promote your small business that you started up as a part of your dreams journey. And we also ended up doing something that really, really we're so proud of, and it was how to just adapt in the times of COVID that we experienced at some point while rolling this out. We didn't want to completely suspend what was happening, but as COVID-19 contingency, we decided that we could make an agreement with our skilled providers of the service to have the girls actually take some of these insured gadgets to their homes and then practice continuously their lessons and then returning them to the center when they were done. Next slide, please. So here, this is just a picture I wanted to show of some of the girls who ended up being attached to a prestigious internship to practice these skills further at the University Teaching Hospital at the Information Technology Department. And they're holding their smartphones there that they were awarded just to help them keep practicing the skills they have learned. Next slide, please. And just to wind up my presentation, we had learned a lot that was very valuable through implementing dreams. And one of them was that when you were implementing the project within the community, it was very, very important to listen to that AGYW feedback, to listen to what they were recommending as ways to make the project even better than it was. And so we had these anonymous suggestion box where they would give us all this feedback. And really, this is how we ended up designing some of these, co-designing some of these innovations that I've spoken about. Most of them did come as ideas from amongst the girls themselves. And it was also very important for us to strategically, scale up our numbers, scale up and scale down our number of mentors that were there to really roll out this project for us, because it really got to balance out the numbers based on who we're hoping to reach. So as you can see on the screen, these are just some of the most important reflections that we would like to highlight today. Next slide, please. So thank you so much for listening to my brief presentation. If you would like more information about these key innovations that I have highlighted, because there are many more, we would like for you to just log on to the PACT website and just download our project compendium that now goes into further detail about all of these. Thank you so much.
Thank you so much, Lisa. And up next, we'll hear from Mulima Walubita, who is our Monitoring, Evaluation, Research and Learning Advisor, who will highlight key findings from an outcome survey that we conducted from the adolescent girls and young women who participated in the DREAMS program. Welcome, Mulima.
Thank you, Mariana. Good morning, good afternoon, and good evening to everyone. My name is Mulima Walubita. I will be sharing the DREAMS Endline Survey findings and recommendations. Next slide. This is the DREAMS theory of change. So the DREAMS theory of change was adapted from the London School of Hygiene and Tropical Medicine Research Protocol. So the DREAMS theory of change hypothesizes that the DREAMS core package of services, the uptake of the DREAMS core package of services by adolescent girls and young women results into psychosocial short-term outcomes, a selection of them that in turn yield long-term outcomes, which support the reduction of new cases amongst new HIV cases amongst adolescent girls and young women aged 10 to 24. Next slide, please. So the study objectives were to uncover the extent to which the DREAMS package of services had led to expected positive short and long-term outcomes for adolescent girls and young women across the initiative's theory of change, to uncover the extent to which successes achieved immediately following DREAMS participation have been maintained beyond 1 year after participation in DREAMS, and to provide evidence of Z-CHPP DREAMS contribution towards a reduction of HIV incidence among adolescent girls and young women in Zambia. Next slide. So this slide basically shows the study methods that were used. So this was a multi-stage cross-sectional study design that triangulated existing project monitoring data with primary data collected for the purpose of the study. So we did have enrollment and graduation. So for the enrollment and graduation service, this was administered to the same girls, while the 12+ months post-graduation was administered to a separate sample of adolescent girls and young women that participated in DREAMS. And the 12 months post-survey graduation results were compared with the enrollment data. So in terms of the sample size, so for enrollment, we had 2,988 girls, graduation 2,791, and post-graduation 1,352 girls. Next slide. So HIV-related knowledge was also assessed using a set of 6 standard questions. And some of the questions that the girls responded to were whether HIV whether art can cure HIV, and whether having multiple sexual partners can increase their chances of contracting HIV. And looking at the results that we got, we see an interesting trend across the different age bands, 10 to 14, 15 to 19, and 20 to 24. So we see very good results at graduation. Looking at the average score, for instance, especially amongst the 10 to 14-year-olds, that scored at 4.4 at graduation. And for the 15 to 19, 4.5 compared to enrollment data, which was at 3.2. And 20 to 24 was 4.4 compared to enrollment data that was at 3.4. However, 12 months post-graduation data did show us that the results were not sustained, especially for the 10 to 14 year age group, where the score reduced to 2.9. Next slide, please. So for this slide, we look at the empowerment component, and for the empowerment component, we look at self-efficacy in sexual activity amongst the adolescent girls and young women. So part of the questions that the girls responded to was whether they were able to avoid sex anytime they didn't want to have sex. And again, we see some statistically significant results amongst the 15 to 19 and the 20 to 24-year-old adolescent girls and young women. For instance, at enrollment, we see that only 30% and 22% of the girls were able to avoid sex. And at graduation, we see an increase in the number of girls that were able to avoid sex, which rose to 52%. And at 12 months post-graduation, this was sustained and it increased to 80% for the 15 to 19-year-old and 63% for the 20 to 24-year-old. Next slide, please. So decision-making in relationships was also assessed around questions of condom use, and we do have some significant good results. Next slide, please. So measures of stigma were also assessed, and again, we did see some very good significant change in the results at post-graduation compared to enrollment. Next slide, please. So mental health was also assessed just to ascertain the mental, to check the extent at which participating in DREAMS program helped the girls have good mental well-being. So looking at the results that we got, we actually have a very interesting results that we got from this survey. So for the girls, so for the 10 to 14-year-olds, let me mention that for mental health, a higher score signifies that there is poor mental well-being, and for the a lower score signifies a good mental well-being. So we noticed that at enrollment, most of the girls scored high scores across the age bands, and you can see that this tells us that mental well-being at that point was not very well. Then we come to the graduation, where graduation immediately after participation in DREAMS, and we see that the average scores for the girls across the age bands reduced to 4.9, 6.4, and 4.9. This clearly tells us that there was good mental well-being amongst the adolescent girls and young women immediately after participation in DREAMS. Then at 12 months post-graduation, we again see that the results, the scores did rise. For instance, the 20 to 24 and the 15 to 19, it was poorly sustained as the scores rose to about 8.8 and 9.5. Next slide, please. So condom use was one of the outcomes that was also assessed, and the question that was used was actually condom use with most recent sexual partners. So the girls were asked, and we did see a significant shift in the results from not often using condoms to very often using condoms. At enrollment, we saw 82% of the girls not often using condoms. And at 12 months post-graduation, this reduced to 45%, which was a good indication. And at 18% at enrollment, we saw only a few girls said they were using condoms very often. And this also increased to 55% and 12 months post-graduation, giving us a good picture that adolescent girls and young women were now using condoms more often. This is one of the picture that the Z-CHPP project really wanted to see throughout this program. Next slide, please. And finally, awareness of HIV status was also compared at enrollment and at 12 months post-graduation. So you notice that at enrollment, we had about 48% of the girls who were not aware of their enrollment status and of their HIV status. And this reduced to 28% at post-graduation, telling us that more girls now are more aware of their HIV status. And for those who knew their HIV status at enrollment pre-intervention phase, we see 52% of the girls. And then this also increased to 72% at post-intervention, clearly giving us a picture that more girls were now aware of their HIV status. Next slide, please. So in terms of limitations and strengths of the study, so this was a cross-sectional at each point of assessment as opposed to longitudinal. And 2 samples of the adolescent girls and young women were used in this study. Then only outcomes for which comparable baseline data already existed from standard programmatic tools were included in the 12+ months post-graduation survey. And in terms of the strengths, the findings would definitely fill the existing gap in the evidence base, as well as inform adaptation and future HIV programming for adolescent girls and young women aged 10 to 24 years in Zambia. Next slide. So some of the key takeaway points from the study are that we've seen an overwhelming positive changes among adolescent girls and young women that participated in DREAMS. Then the short-term outcomes were particularly more successful compared, giving us a clear evidence of the effectiveness of DREAMS activities and of the DREAMS theory of change. Then several of the outcomes did not maintain the positive trajectory seen at graduation. Some of them were HIV knowledge, as well as mental health. But I must mention that even though the trajectory was not maintained, this was statistically significant compared to baseline data. Then long-term outcomes also showed positive results, which are critical elements leading to reduced HIV new cases among adolescent girls and young women. So DREAMS has proved to be a good platform in increasing HIV knowledge, reducing stigma, and in enhancing resilience among adolescent girls and young women. Next slide. In terms of recommendations, one of the first recommendations is to enroll the 10 to 14 age group once adolescent girls and young women mature and enter the next cohort, or to conduct sessions at intervals beyond graduation for the 10 to 14 age groups. So this is basically to enable the girls return back into the sessions and learn more, as we have seen that some of the good results that were recorded at graduation were not sustained at 12 months post-graduation. So enrolling them would give them an opportunity to learn more and access more services, especially that when they're graduating at 10 to 14, some of the services that are in the age band 15 to 19 and 20 to 24, they are not there. So once they enroll back, they will be able to access those services, especially the biomedical services. Then to continue with condom promotion and distribution to reduce the disparity seen in the 20 to 24 age group in self-efficacy in sexual activity amongst the 20 to 24, and to provide mental health services throughout the life of the project to sustain positive outcomes post-graduation. So this is again because of the services that were not, the good results that were not maintained at 12 months post-graduation. Thank you for listening.
Thank you very much, Mulima. Next, we'll hear another community voice. A young lady named Grace will tell us about her experience in participating in the DREAMS program.
I want to be an advocate for young people that went through the mistakes that I did. I encourage them, you know what, you just keep on coming to dreams. It will take us far. I experienced gender-based violence. I was raised by my grandparents. Yes, so after completing school, I was invited by my aunt to go stay with her. When we started staying there, everything was all right. Not until I discovered that his husband started abusing me, like harassing me sexually. The bedroom that I was sleeping in, it didn't have a door. So when the wife goes to sleep, he used to come to my room. I used to scream, but the wife never used to come out. My only solution was to run away from that place. I decided to go to my boyfriend's place. After I stayed there for 3 months, I found out that I was pregnant. I told him about the pregnancy, of which he refused, and then he chased me out of his house. I was depressed. I didn't know of how to use condoms, of how to use safe sex, to practice safe sex, because I got my second pregnancy due to lack of knowledge of using condoms. I lost hope in myself. I thought being rejected by 2 men and then having to be a single mother at a young age, I never thought I would go far. I started coming to Dreams Center last year, November. Apart from testing, apart from family plannings, I also went through mental health services here, yes, which really helped me a lot. I got away from depression. I'm no longer depressed, yes.
So if the viral load is high,
they were teaching us on how to prevent yourself from getting HIV, how to prevent yourself from getting early pregnancies. So after I learned all those things, I got interested, saying, this is the knowledge that I needed all along. If I knew this way back, I don't think I was going to have 2 kids without fathers. Dreams has helped me. I've been empowered. I have to negotiate for sex. I have got that right as a woman to negotiate, saying, if you want sex, let's use a condom. If you don't want to use a condom, no sex, because I want to protect myself. In this, our community, a lot of girls are passing through what I passed through. And then they don't have that knowledge of the knowledge that I got from here. As youths, we don't want to accept that HIV is there, HIV is real. So I'm helping them, saying, even though you're young, being found positive, stay on medication, life still goes on.
Even if you are raped, please don't stay at home, because you won't know the person who raped you. Maybe he's HIV positive or he's got an STI. You have to rush. If you don't have somebody who you can talk to, who you feel you are free, because I know, I'm sure here you are free with us. Are you not free with us?
Yeah. When you come here, they welcome you with love. They make you feel at home. They protect you as a girl. But Dreams has helped me to push, saying, I will make it. I will have a brighter future ahead of me.
And now I'm honored to welcome Emily Barrows, the PEPFAR Dreams Coordinator in Zambia, to share with us PEPFAR's vision for the future of dreams in Zambia. Welcome, Emily.
Thank you so much, Mariana. And I'm so pleased to be here today to represent PEPFAR Zambia at this event and to really celebrate the work of PACT under the USAID Z-CHPP program. I'm especially happy because I'm speaking to all of you today from the Maramba Dream Center, which Z-CHPP was so instrumental in building in this community and with the community and the adolescent girls and young women who have passed through its doors. So really thrilled to be here today. As we've heard from people like Lisa and Mulima and in particularly Grace, the Dreams program has just had an incredible impact on the lives of so many adolescent girls and young women in Zambia, over 800,000 so far and counting. I wanted to share just a little bit of an anecdote of somebody I learned about today that it just really struck me. Her name is Raquel, and she works at a dream center in Livingston, but she didn't start as a dreams mentor. 5 years ago, she started as a dreams girl and aspired to be a mentor so she could help other girls in her community. When I asked her if her parents had originally been concerned about her joining Dreams, she said, my parents, no. My parents are the one that hosted the safe space at their house. They're the ones that encouraged other parents and young girls to come to the Dream Center. So it was just such a really wonderful thing to listen to her story about how she enrolled as a Dreams girl, grew into becoming a mentor, and convinced her other 5 sisters to go through the program as well. So I think those are really just immeasurable. We heard from Ulima the measurable way that Dreams has had an impact, but there's so many immeasurable ways that we don't see that Dreams has had an impact on girls' lives. Looking beyond those personal stories of girls and young women, the Dreams and girls and the mentors whose lives have changed through their engagement in Dreams, the data tells us that Dreams has had a measurable impact. We saw that from Ulima. But data released on World AIDS Day in 2020 showed that HIV incidence among AGYW in the 8 Dreams districts where we operated at the time had reduced by more than 40%. That is an incredible achievement. It's just remarkable. But we also know that the HIV epidemic continues to disproportionately impact adolescent girls and young women. They face social isolation and poverty and discrimination and gender-based violence and inadequate education. All of these things persist, and these barriers really hold us back from progress in the HIV response. And this is why Dreams remains relevant in Zambia even today. In reimagining PEPFAR's strategic direction, the U.S. Global AIDS Coordinator, Dr. John Nkengasong, has renewed PEPFAR's commitment to ensuring adolescent girls and young women remain at the center of HIV prevention efforts, with support from their families, their partners, and their communities. Ambassador Nkengasong's strategic document refers to, quote, the next generation of Dreams, which is firmly rooted in meaningful leadership of government, civil society, and communities, supported by innovation and grounded in evidence. And so as we look to the future for Dreams, community leadership stands out to me as a really important component. Dreams needs to better integrate community voices, not only during the program implementation phase, but the design phase and the monitoring phase to deliver meaningful outcomes to adolescent girls and young women. And this requires leadership capabilities and expertise of young people to point us to, for example, underrepresented peers and communities, and to advocate for their interests. I think another thing is innovation. This is critical. We need to remain attuned to the rapidly changing environment that ushers in new technologies and scientific breakthroughs and products. We adapted Dreams when PrEP came on board, and we saw the incredible uptake of PrEP among Dreams girls, adding another effective prevention tool to our toolkit, a package of prevention services. We need to plan for thoughtful integration of similar products and tools in the future and be prepared to be flexible for how we integrate them. And I think Z-CHPP's been doing a great job at that. And finally, we need to lead with data. One thing that has struck me at my visit this week to 4 different Dream centers is that we have a rich set of data. We have data on the risks and vulnerabilities that over 800,000 girls have faced. And we have data on the services that they've received. And that can help us really gain program insight into what's worked and not worked, so that we can really optimally allocate HIV prevention resources efficiently and effectively in the future. So I think, led by these principles, PEPFAR Zambia is looking forward to continuing to support AGYW on their journey to becoming determined, resilient, empowered, AIDS-free, mentored, and safe. And I just want to send a huge note of congratulations to PACT and the Z-CHPP team for helping PEPFAR Zambia pioneer Dreams in the country. It's truly because of your groundbreaking work that the center that I'm at today, Maramba Center, is so successful and has such wonderful mentors who are able to provide guidance and support to the girls that they welcome through their doors. So thank you so much for the opportunity to speak to you today. Really appreciate you inviting me to talk at this event. And thanks again.
Thank you so much, Emily. And Emily's visionary words bring us to the end of this exciting webinar. We hope you found it useful. In the chat box is a compendium that is really a toolkit of the success of this program that everybody can use to replicate, to scale out these amazing interventions. We want again to thank everyone who collaborated in this program and made it a success, reaching 1.9 million Zambians and really contributing meaningfully to HIV prevalence and incidence reduction. Thank you again so much to everyone who was able to participate. Thank you.